Hi, you are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. Hello and welcome to another exciting episode of In the Ladies' Room with Dr. Donica. Now, true confessions. I've had a recurring nightmare for the past, probably over the past 30 to 40 years, that I wake up in a cold sweat after dreaming about being in college and having either a physics or calculus exam the next morning and having cut all of the classes. And sometimes I wake up and I have to convince myself, okay, yes, I did graduate from college in 1981. And yes, I did graduate from medical school. It's okay. And it took me about 10 years of having this dream before I finally confessed it to friends of mine. And it turns out this is very common. And what I'm going to ask our next guest is if this can be related to imposter syndrome. Now, I'm not going to tell you what it is. I'm going to leave that to our guest, Dr. Jennifer Hunt. She's the Chair of Pathology at the University of Arkansas for Medical Sciences. She served in a number of different leadership roles, both at her institution and nationally, including Chief of Staff for her hospital. She's an elected member of the Board of Governors for the College of American Pathologists and President of the Association for Molecular Pathology and President of the College of the American Pathologists Foundation. She has a bachelor's degree in chemistry from Bryn Mawr College, so I know she took physics and calculus. And she also has a combined MD, medical degree, and a master's in education, MED, which I didn't even know was a combination thing, from the University of Pennsylvania. She also did her residency training in pathology there, as well as a fellowship in molecular genetic pathology. Prior to becoming Chair of Pathology at the University of Arkansas in 2011, she's held academic, clinical, administrative leadership positions at the University of Pittsburgh, the Cleveland Clinic, and Massachusetts General Hospital, which is part of Harvard. So you could say she's quite accomplished. But there'd be a whole nother part of the story that we haven't even told yet. Because like many super busy, super accomplished women, she does much, much more. Yes, she's also the proud mother of 3 kids who are all competitive swimmers. And coming from a family of 6 competitive swimmers, I can tell you that running that organization is a major commitment. But even though she's a self-proclaimed terrible swimmer, she is a certified USA swimming official. I don't know why anybody would do that voluntarily. And a certified CrossFit Level 1 coach. She coaches group fitness programs with a particular interest in Olympic lifting and strength training. So we want to hear about that too. But as if all that wasn't enough to make me feel like a slacker, she has a second distinguished career. She maintains a practice as an executive leadership coach, which focuses on current and emerging leaders in healthcare. She runs a very popular leadership development program for women to address the imposter syndrome in medicine called Unlocking the Authentic Self. So with that, please help me welcome Dr. Jennifer Hunt. Have I made you feel like an imposter with that huge bio?
You know, introductions often bring out the imposter syndrome in us. It's kind of like you want to shrink into the floor when you hear them.
Sometimes I feel like, who are they talking about? How could one person do all that? This isn't realistic. And I want to get into this right away. Now, our audience, of course, we have a lot of women physicians who listen and men physicians, but we also have a lot of people who are not physicians and who are not in healthcare. But this imposter syndrome concept applies across the board, from what I understand.
Absolutely. This affects people in all walks of life and all professions, and it affects men as well as women.
Right. I was going to say not just women, but of course it affects, like many things we talk about in the ladies' room, it affects women disproportionately.
Absolutely. Well, I should say, I believe that's true. There is some literature that suggests it's more equal, but in my profession and where I sit, I think it's much more common.
Well, I did see one study that looked at women physicians. Actually, no, I saw 3 studies. I forgot to count residents as physicians.
Yeah, right.
But so I have seen 3 studies that have looked at physicians and residents and showed that it's about almost twice as common in women. And I definitely want to get to that. But first I have to ask you the burning question on all our listeners' minds. And that is, what is the most unique, interesting, or different experience you've ever had in a ladies' room aside from this interview?
Oh, I'm so glad you changed it from conversation to experience, because I do have an interesting experience in a ladies' room. I don't have a great conversation, but I have a great experience. My husband is Malaysian, and when we first started dating, I went to Malaysia with him, and we arrived in I think it was the Kuala Lumpur airport, and I had to go to the bathroom so bad. So I raced over to this bathroom, and I went in, and I closed the door, and I looked at this bathroom, and there was no toilet. There was just a hole in the ground and like two places to put your feet. And I had never in my life seen a toilet like this. And I managed. I fumbled through the whole experience, but when I left, the conversation was interesting with my husband. What was that? That was not a bathroom. Now I'm used to it. Now I'm okay.
Many of our guests have shared stories of international restroom experiences that involved a hole in the floor. One of these days, I think I'm going to write a book about collating all of these really interesting and memorable experiences, because they're diverse and they're fascinating. But so, speaking of diverse and fascinating, clearly in your career, you became a pathologist first. How does one go from being a pathologist and a mother of three and a competitive swimming official to then becoming an executive coach and taking on this issue of imposter syndrome?
Well, that's a great question. I think there's no logical sequence to it. I'm going to say that the logic behind it is my own professional restlessness, not any kind of sequence that makes any sense. And I think for me, it is actually a natural progression from my mentoring and working with young faculty through becoming a chair, and then expanding that even more to becoming an executive coach mostly for women physicians, although I do coach a few men as well. So I think the more natural progression came from being a chair than definitely not being a mother. Oh no, there's no natural progression from that.
So did you go through any kind of executive coaching first as the client before you then decided to become an executive coach?
Yeah, I've actually had coaching throughout my career. And it started when I was at the Cleveland Clinic, when they actually had a coaching division for
Wow.
For the employees. It was kind of a secret back then. And I don't know, I stumbled into it and had a wonderful executive coach really for the whole time that I was there. And I've kept in touch with her since then too. So I've had coaching for a long time.
I spent a large portion of my career on the business side of medicine as a medical director at an international pharmaceutical company. And executive coaching was fairly common for business executives, but you're the first person I've heard of who's told me that she's gone through executive coaching as a practicing physician.
I think it's
there also is an organization that does executive training for physicians who want to transition into business. And of course, the irony of medicine is that very few of us get any business training along with our medical training. So that's a whole nother episode. But what drew you to the idea of becoming a coach?
I think it really started when I thought about the gaps and the insufficiency of mentoring. It just didn't feel like I was doing enough as a mentor. There was more out there. There was more to gain in the interactions that I have with my faculty and with other faculty elsewhere than just the traditional mentoring role. And as I thought about it, I really thought back to all my experiences as a coachee and thinking, yeah, that was what was missing. That's it.
And were you already a department chair at this point?
I was. So I only started doing this about a year ago.
Great.
And so it's been about a year that I've been really doing executive coaching myself.
Okay. And for our listeners who are not in medicine, I have to say what a big deal it still is for a woman to be a department chair at a major academic health science institution. And it's unfortunate that I still have to say that in 2019, but that's true. Anyway, tell us, what is imposter syndrome?
So imposter syndrome, first of all, I have to say I hate the name, and I'll get into a little bit of that probably as we talk.
But I kind of like it. I actually remember reading about it probably in the early 1980s and saying, oh my God, that is like such a great thing. But tell us what it is and tell us why you don't like the name.
Okay, so imposter syndrome is really constellation of thoughts inside of a person where they see their own value as less than the world sees their value. And so if you think about it, it's a mismatch between the internal view of yourself and the external view, or the external evidence of yourself. Not just your self-worth, but your value, your accomplishments, your drive, everything about you. And so I like to think of it as a mismatch between the two, between what you think inside and what the world sees outside.
So basically, you're giving yourself a lower grade than everybody else is giving you.
Devaluing yourself incredibly. Yes.
And let me just take a wild guess. Is this more common in type A individuals?
So the type A is probably the most well understood of all the personality assessments. And yes, it's also, you can also think of it as just much more common in highly accomplished individuals.
Okay. And so why is it more common in women?
Great question. I don't think anybody knows why it's more common. There's a lot of postulation that it comes from the teen years, and there's a lot of thought that it probably comes from the family environment, the expectations, but I don't think anybody knows why it's really more common in women than men.
I think it would also be interesting to do a comparative study, and I'm quite sure nobody's ever done this, between women, say, my age, which we'll just say over 50, versus women, say, who are residents now, so in their 20s. And I wonder if the social dynamics have changed. Because for women my age, I think it's pretty clear that many of us felt we weren't supposed to be where we were. We weren't supposed to be in the room, or we were the only women in the room. Or in those calculus and physics classes that I keep having nightmares about, very often I was the only woman in the room. And, that certainly had an effect. And I think there was also this dynamic of you got where you were because you were lucky, or because of your charm and personality, or worse. That whole thing about, women being able to get promoted through various inappropriate relationships, which in my experience does not happen.
Yeah. Yeah. Well, you're hitting on so many buzzwords from the imposter language, and those are being a fake or a fraud, feeling like a fake or a fraud, feeling like you only accomplish what you do through luck or charm. That's another classic one. So yes, it probably did start as an external force, but most of that is internal. Most of that's what we think inside. And so, I think that there is some of that comes from that history. Now, you also asked whether there was a difference between generations and whether we've come a long ways or not. And you know what? I see no evidence that we've come a long ways. All these women that I'm working with are in the younger generation. They're not 40 or 50. They're 30 and 35, coming out of residency, early career. And they think the same things. And so they weren't the only woman in the room in their medical school class, and yet they still think, I only got here because I'm lucky. They made a mistake. I am the one person they sent the wrong letter to.
Now, I will tell you, in terms of that, I've now been out of college for almost 40 years. And I went to a very competitive Ivy League school. And every single graduate I've talked to from my school, from Princeton, has said they felt as an undergrad like they were the one who got the mistaken letter, or that they only got in because of connections, or they only got in because of their athletic prowess. I was very lucky because I didn't have any connections, so I knew that wasn't. I used to joke that I only got in because I promised my brothers would come after me.
Oh, yeah.
We all had to figure out, why. And I think what that reflects is the recognition, in part, that a lot of success is because of chance. In terms of things like, getting the golden ticket to go to a very privileged school or privileged education. And I think a lot of it is the recognition that a lot of other people could have accomplished what we accomplished if they had similar opportunities. And a lot of it is the recognition that, hard work can only take you so far. And I think a lot of it is also about sleep deprivation.
Certainly in the early careers when you become a physician, it's about sleep deprivation. Yeah.
And so, and
I
how
will
much is
say that,
about, how much is about burnout?
oh, burnout and imposter syndrome are intimately linked, and nobody really knows the contribution of each to each other. But what I do see is that the rate of burnout is, well, we know the rate of burnout is really high in physicians and women physicians in particular. But I do see a relationship between imposter syndrome and burnout. And really interestingly, and I have not, this is the first disclosure of these data, that the work that I've been doing through this program, this training program, the rate of burnout decreases. The burnout level decreases when you start to deal with imposter syndrome. So that to me is really, really great for one thing. But it's
So
also
breaking news on
breaking news.
podcast.
That's right. That we can decrease the burnout through dealing with the imposter syndrome and imposter tendencies.
So why don't you like the name imposter syndrome? Although I could probably guess.
Yeah, well, first of all, I don't like the name because it sounds like a disease. It's not a disease. It's not in the medical books as a disease. It is abnormal. It is not the normal way or the resourceful way to live our lives. And so although I don't want to call it a disease, I also don't want people to just say, oh, well, then it's fine. I'll just keep going. I'm good with my imposter syndrome. So I don't like the name because it sounds like a disease. But I also don't like the name because if you think about diabetes, you have diabetes, you're a diabetic. If you have imposter syndrome, you're actually not an imposter. You just think you're one. And so it doesn't reflect the underlying issue. So what I like to call it, and I haven't gotten anywhere with this, so it's not gotten any traction, is self-depreciation syndrome. And I don't mean self-deprecation. That's a whole other issue that I hate too. But self-depreciation, it's self-devaluation. You're devaluing yourself as compared to what the world sees. And so I think that reflects better what the underlying process is.
Well, and I thought that's where you were going to go with why you didn't like the term imposter syndrome, because it reinforces the negative imagery and the negative consequences of feeling like.
It does. It does. In fact,
feelings of inadequacy.
In fact, in my first cohort that came through, I called it the Imposter Syndrome Program, and they complained, I don't want to see this email every week. Please don't send me this email.
So tell us again the name of the program.
So the new name is Unlocking the Authentic Self.
Very, very good. And so right now you're only offering this program to women physicians. Is that correct? Or physicians in general?
Only women physicians. I would be happy to run a men's cohort, but I think it's really important to have the genders be specific in the cohort. There's a lot of really great sharing and really important vulnerability and disclosure. And I think it's really important to keep it women or men in the group.
And you do this live, but online.
So yeah, so it's a virtual. Yep. Oh yeah, we keep the cohort pretty small. It's a really interactive session. So we do live sessions once a week with the participants, and it's interactive.
From doing this?
Oh, so much. So I've learned a lot about imposter syndrome, and I've learned a lot about women physicians, and most importantly, I think I've learned a lot for myself and about myself. If somebody asked me, I was having drinks with a friend a couple months ago, and he said, well, you don't have imposter syndrome, do you? And I said, of course I do. And he said, well, when did you have it? And I said, well, last week, and I'm running the program. So I've learned a lot about myself as well through the whole process.
Well, I would imagine that feeling that you had a connection to this constellation of symptoms is what drew you to do the course. I mean, I think that was so obvious. I didn't even ask that question, but I will ask, at what point in your life or in your career did you first feel like you may have had this?
That's a really great question, and I have a very specific answer.
Okay.
And I did not know about imposter syndrome until my residency. During my residency.
But it wasn't even named until 1978.
That's right. And even then, I don't think it got a lot of publicity. So it's been kind of under the radar. But one of my attendings, I probably said something like, I don't know, I was just lucky. I don't know. I said something like that. And he said, imposter much?
Oh.
Mm-hmm. And I went home and I thought about it and I read about it. And that's the very first time I really reflected on, yeah, maybe so. Maybe so.
So I was trying to think about in my own life when the first time I may have had feelings of this. And I actually traced it back to high school. My claim to fame, speaking of competitive swimming, is I was the first girl in New York to compete on a boys' team under Title IX, because we didn't have a girls' team. And I remember very clearly that at the end of the season, I made the all-city team, and there was a photograph of me and all of the other members of the all-city team, and I was the only girl. And there were so many letters to the editor about what's this girl doing in the picture. And just because of the logistics of the photograph, I was fully dressed and they were all in bathing suits and sweatshirts. So that also was a disconnect. And then going to a college, which at the time was only 25% female, and coming from, a really disadvantaged area of Brooklyn, New York, and going to Princeton, which was like going to Oz for me. So I thought about all of these things, but I cannot remember when the first time I started having that dream was about, the sleeping through the exam or missing the exam or being totally unprepared. I figured out it was physics or calculus because there's no room for creativity and baffling your way through, an exam in physics or calculus if you don't know what you're doing. But how does that dream, do you think, reflect the insecurities or the anxieties that people have, especially so many years later?
Well, first of all, I share the dream. We're dream twins. I mean, mine's a slightly different one, but it's same theme. And I think a lot of people have those recurring dreams. Probably psychiatrists could have a field day with our dreams about that. But, how does it fit in with imposter syndrome? Well, I think those dreams are in our mind in real life with imposter syndrome. We are so paralyzed by fear of this failure or fear of not being perfect or fear of not being overly prepared, not just prepared, but overly prepared. That's real life in imposter syndrome. So it's almost like it plays out in real life.
I think also, the older we get and the wiser, hopefully, that we get, the more we realize that we don't know. And it actually compounds itself. When I was in college taking a calculus exam, if you were prepared, it was possible to reasonably know the material and you would get a very specific grade that would reflect that, and it would reflect what you didn't know and what you knew. Life isn't like that. You don't get a grade. One of the characteristics I know is I still remember every poor patient outcome that I ever had. And I haven't practiced medicine since 1993. But I still remember, I don't remember the names of every patient. And I'm not saying that the poor outcomes were my fault, but I remember everyone. And I think that as physicians, we have that additional burden of the mistakes or the poor outcomes just have far greater consequences than if you worked at the Gap and you gave somebody the incorrect change. Which might seem like a crisis on that day, but, nobody died. Or maybe you got fired, but nobody died. So that also might contribute, I think, to the burden that physicians have. What else contributes to physician burnout?
Well, of course, there's tons of literature on physician burnout. And I mean, these days, I think most people would put number one on the top of their list, the electronic medical record and overload from informatics, the side of things. But certainly the perfectionism that you're talking about, and, that negativity bias that our brains have to store all those negative experiences and emotions contributes to burnout as well. I think that's when you think about all those patient mistakes, are you remembering all the 5,000 comparative great outcomes?
No.
Not ever.
Not at all.
Ever. So for every one bad thing that happened, you've got to think probably 5,000 good things, maybe more good things happened, great outcomes, patients whose lives you changed and who would think of you as so important to them in their lives. You were OB-GYN?
OB-GYN.
Yeah. So how many babies?
Which in general is a fairly happy specialty.
Yeah.
But I think the contrast then is when a baby dies, or when a mother dies, or when you do a radical vulvectomy on a 23-year-old who has, vulvar cancer. These are the patients that you remember. I had a perfect delivery with a patient with no risk factors and no complications on April Fool's Day, and the baby died for no reason. And and it still haunts me that we didn't know the reason. I think that's the other part of it, is that many times we can identify what the problem was, but many times we don't know. The other thing, the way our system is structured, many times we don't really know what ultimately happened to that person. Now, in that particular case, I actually delivered that same patient the next year on April Fool's Day, exactly 1 year later.
Wow.
And it was the only delivery I ever did where there was silence in the room. It was just completely silent until that baby cried. And it was, that was a joy. That was real. And, hugging and kissing and photographs and everything. And it was just amazing. So yeah, I do remember sometimes, but most of the patients with poor outcome, I have no idea whatever happened in their lives.
Yeah. Yeah. And in imposter syndrome, we store that really well. So we're really, really good at storing those negative, high emotion, terrible experiences. And we're really bad at recalling the really positive things. I see this a lot with annual reviews with physicians. They come out of their annual review and they're devastated. It was terrible. And I probe and I ask, well, tell me what the terrible parts were. Well, the chair told me that I need to write more papers. And what else did the chair say? Oh, nothing. Well, so you had an hour conversation and that's all the chair said. And what happens is we forget all of the positives. They're gone. They're just gone in one side, out the other. But we're so good at storing those negative or critical pieces. And
and I really want to underscore, this is not unique to women physicians. No. This is not unique to professional women. Everything that you're saying could be said by anyone who's had a child, certainly anybody who's had a teenager, those negative experiences or negative times often stay with us. I think one of the things that I've been very concerned with, though, about physicians in general with respect to burnout, which we are hearing and talking a lot more about physician burnout, but we also, I think, have to talk about the extreme cases and talk about physician suicide. And we've talked about suicide from a number of different perspectives on this podcast, just because I feel the obligation to, because most people still aren't talking about suicide. And we know in general, among the adult population, suicide is more common among men. But in physicians, suicide is actually twice as common among women. Even among men, suicide in physicians is significantly higher. Have you ever talked to or counseled women physicians who have thought about killing themselves or confessed that they had suicidal thoughts? The percentages are staggering of the numbers of residents who have suicidal thoughts.
Yeah. So obviously I totally agree with you that this is a topic that needs to be discussed more nationally and get more visibility. In the coaching world, there's a really clear distinction between what coaching is for and what therapy and psychiatry is for. So I'm really careful about making that very clear distinction. So fortunately for me, I have not had those conversations. And, of course,
but as a department chair, you must have had those conversations.
I have to say, fortunately, I have only had to ever ask the question once.
Wow.
And I feel very fortunate that's true. And I hope that it's not because we're just not seeing it and missing it. We also at my institution have a really, really robust physician assistants group who's really professional and behind the scenes. So we're able to handle a lot behind the scenes before people get to the point that the burnout is so severe that's a consideration.
I actually remember grand rounds once when I was a resident where there was a speaker who talked about drug and alcohol dependency amongst our patients, not amongst our colleagues.
Mm-hmm.
And he asked us to think about what percentage of our patient population were alcoholics. And most of us came up with numbers like, oh, we had 3 or 4 patients who were alcoholics. And he said, if you don't have 10% of your patients who are known to you to be alcoholics, you're not making the diagnosis, because that's the national average at that time. Yeah. And that really struck me, how many times we're not making a diagnosis because we didn't ask a basic, simple, or a direct question. So back to imposter syndrome. We tend to wander off the topic in this podcast.
Great talk.
What are the questions that you ask to determine if somebody may have imposter syndrome? I know you have a wonderful assessment, which I took. I don't know if I'm ready to share my score on that.
You don't have to share it.
It's actually counterintuitive, because as somebody who's an overachiever, you want to get a high score. But on this
right,
test,
but not on this test.
On this test, 100% would be really, really bad. So I got a 74%, which is right in your sweet spot of
right
who may have it. So tell us some of the criteria.
Yeah, so really the criteria revolve around these thoughts in our brains around being a fraud or a fake, feeling like you're a fraud or a fake, feeling like your accomplishments are diminished, that they're not as significant as other people think. A lot of times people also have this experience of not accepting criticism well, or not being able to accept criticism, feeling really devastated if anything is criticized about them. That's another really common one. And then I see really frequently in women physicians this underlying perfectionism, which probably is what got us here in the first place in many ways, but it's beyond resourceful. It's a perfectionism that you can't live up to, and then after that feeling like you are so bad because you didn't live up to your perfectionism characteristics. So it's a self-fulfilling prophecy in many ways. And so those are just kind of some of the things that we see in imposter syndrome.
So talk about perfectionism a little bit. Where perfectionism to a point can help you become very accomplished and very well organized and get things done. But after that point, it can actually be a destructive force, and it can actually be paralyzing. So talk about that dichotomy.
Well, it's a great opportunity to talk about a tool that I love to use, because, hey, the people listening to the podcast might go away saying, hey, give me something I can do.
Yeah,
here you go. With
tools.
Your 74%, here you go. And that is embedding a choice point into your life. So it is totally okay to choose perfectionism. It is not okay for it just to happen. So if I decide that I have a paper that I'm writing and I want it to be perfect, and I spend the time to make it perfect, if I've decided that and I choose it and I consciously elect to do that, great, spend the time and do it. What's not okay is to get into these cycles where I can't put it down, I can't submit it, I cogitate, I work on it, I fuss with it, and I never submit the paper because it's not perfect. So I think if we can embed these choice points and say, is this my choice or is this perfectionism? Then you can get a lot further in handling it. And to me, that's the real answer to a lot of the issues in imposter syndrome, but particularly perfectionism.
So what I hear from a lot of women who do make a choice to focus on one particular part of their responsibilities, or say a paper, which is a good example. But then they beat themselves up about all the other things that didn't happen as a result of that. So the house is a mess, you didn't get the, cupcakes made for school for the student function, or you didn't get to your child's swim meet, or you forgot to do the laundry for 4 or 5 weeks. The bills didn't get paid, whatever it was, and I think, again, that's something that I hear from women, regardless of, what their career is, especially the more multiple roles that we're taking on, and the more multiple dimensions have to be attended to simultaneously, something is bound to fall through the cracks.
Yeah.
So,
you know what? The thing is, you have to actually make the choice on both sides. So you also have to acknowledge a choice to do something less than. And I actually give homework. I just gave somebody that homework this week to pick something every day that she does crappy on. I am going to choose to do a crappy job on this. And to then say to myself, hey, congratulations me, I succeeded in doing a crappy job. Because really, it's not just about choosing perfectionism, it's also about choosing priorities and deciding that I am not going to be perfect on this, whether it's the house or, I mean, you probably should do your laundry more than once every 5 weeks, but hey, maybe not.
Or maybe you should hire somebody.
Absolutely. I'm a big fan of that.
Teach your teenager to do laundry week. That is my tool.
That's right.
That is really important. I think also that there's a difference between feeling like you did a crappy job on something because you actually tried and failed, versus doing a crappy job on something because you spent no time on it, because you were spending time on 14 other things, because you made a choice that it wasn't a priority. And I think the other thing is that we really have to distinguish what is important and what is not. The thing about laundry that's so awesome is that if it doesn't get done, it waits for you. It is.
That's right. That's right. And the thing that's so awful is it's always going to be there. It's never done, but that's okay because you can accept that.
Right. And I think we have to prioritize that with other things and, recognize that there's a difference between being successful where we may put our energies, being not successful, where we didn't put our energies. And I think this is particularly important for women in terms of that whole second shift concept. That regardless of all of the other career things that we're doing or not doing, if we're also mothers, that's also not even, I hate when people say it's a full-time job. It's not a job. It's part of your life. It's part of your body. One of my favorite quotes is, making the decision to become a mother is making the decision to forever watch your heart walking around outside your body.
Oh, I love that.
That's not a job. That's a real commitment.
Yeah.
So balancing our personal commitments and professional commitments is something that permeates everything that, we do, certainly as physicians, but certainly also as women in general.
Yeah. And I see that so much with imposter syndrome. It's the same at home as it is at work. You have the same feelings. I'm not a great mother. I'm such a lousy mother. I'm not there for my kids. I'm never home. Same thinking.
Yeah, or over the stupidest thing.
Like
forgetting to make the cupcakes for the bake sale. And could we just eliminate bake sales already?
I know. I'll just give money, please.
I always wanted that to be an option. And I know not everybody is in that position. And I don't want to make light of the thousands and thousands of volunteers in every community who step up to do things for the PTA that raise money for our schools, because we don't have the political will to fully fund our schools. And my heart breaks as the daughter of a high school teacher for 30 years. My heart breaks every time I see teachers using their own meager salaries and their own money to buy school supplies, because that's not provided. So that's a whole nother topic. And I invite anybody who wants to come talk about that topic, to contact me separately. But I think we have to recognize that we all have that undercurrent or that conflict between when your child needs you and your patients need you. Or you've got to write that paper, and it may not have a strict deadline. So it always gets put aside because there's other things that have strict deadlines or are more pressing. So give us some more homework and more tools.
Okay, so
because we're overachievers and now we want to conquer imposter syndrome and we want tools.
Tools. Great. So here's another concept. Imposter syndrome is a reflexive reptilian brain state. Let me just let that sink in. It's not higher level thinking. When we are in imposter tendencies and in the thick of imposter syndrome, we are reacting at a reptilian level. And usually we think there is only one solution, one way, not choices, but one way. It's because we're in this kind of lower level reptilian fight, flight, freeze response. So a great way to exit out of that and to really be able to stop the imposter syndrome, I like to think of it, it's kind of ruminations. I like to think of it as being on a roundabout in Great Britain driving, and you're on the inner circle and you can't get off, and you're just like round and round, and I'm like, how do I get to the outer lane? So how do we get out of that? Well, one way is to just elevate your thinking to the cerebral cortex, move up to higher level thinking. It sounds so easy, but it's so hard. And the way to do that is to just notice what you're doing. So noticing and labeling and identifying the imposter thought can actually be the first step in getting off the roundabout. So instead of thinking, oh, I'm such an idiot. Have you ever thought that?
Maybe once or twice.
Such an idiot.
Usually over the stupidest things.
Yeah.
Like if I forget my phone.
Oh, I'm such an idiot.
I'm a moron.
I left my phone at home. I'm an idiot. Saying,
how could I possibly do that?
So the tool is so simple. It's saying, the judge in my head is saying that I'm an idiot. And immediately you have moved from reptilian brain up to cerebral cortex, because now you're thinking, you're assessing, you're using your higher level thinking to identify, label, and notice the critical voice inside your head. And so that very step alone actually brings you back to present and will be an exit point for you from the imposter tendency ruminations. And so that's another tool I really like is to label and notice the self-critic, the inner critic, the reptilian brain voice, and start to basically call it out. Who is that inside my head?
Well, the only time I really think about or have thought about, now of course I'm going to be thinking about it all the time.
I hope so.
The only time I have really thought about it is in the aftermath of these nightmares that I told you about. And I actually have to, and I kind of do that without knowing that that's what it was called. I actually present evidence to the contrary. Where I actually say, no, you graduated from college. You could not have graduated if you didn't pass those courses. And that means you obviously took the exams and they obviously were okay. You became a doctor. You have a degree. You have a license. These are tangible pieces of evidence to the contrary. And I think that's another thing that is not unique to physicians, but something that we rely on sometimes as a crutch to validate our behaviors is evidence-based decision-making tools.
Yeah. And you're using, when you do that, you're using really the extension of labeling it. So I labeled the inner critic voice, and then the next question you have to ask is that true? And what you're doing is answering the question. No, it's not true. I have lots of evidence that says it's not true.
I have evidence to the contrary.
Are you really an idiot? No, I'm actually not an idiot. I'm reasonably intelligent.
Well, that's one of my favorite movie scenes of all time in The Wizard of Oz, when the wizard presents the scarecrow with a diploma. And he proves to the scarecrow that he has a brain by virtue of having this degree from E pluribus unum. And the piece of paper is what actually lets the scarecrow affirm that he's really not an idiot and he really has a brain.
The evidence. And that's your evidence.
Yeah, the evidence to the contrary. Anyway, I could talk about this all day long, obviously.
And so could I.
What's the one most important thing that you want our listeners to know about imposter syndrome?
Well, I think the most important thing that I teach all the time is that I'm sorry, but you can't get rid of it. I'm sorry. It's not something that we can extract from people. It's not something that can be surgically removed or even psychologically removed. But the best part is that what you can learn to do is control it and own it as yours. It's yours to choose or not to choose. And I think that that's the where I focus most of my teaching and training is around learning the skills to control it. I like to think of it like poor vision, imposter syndrome. I have poor vision because I don't see myself the way other people see me. And I like to think of all the tools, all the things that we learn about as the glasses that you put on so that you see yourself more accurately. Now, you have to remember that you take your glasses off at night or you take them off during the day, you're going to have the same poor vision. So it's something to keep coming back to.
And that's another thing I beat myself up about is losing my glasses. But
Now it's going to be
another story. So where can people find you? Give us all your handles, your Twitter, your Facebook.
Sure. So on Twitter, I'm at jhuntpath, and I'm, sometimes active on Twitter. I like Twitter, so find me on Twitter for sure. On Facebook, I'm Jennifer Hunt, MD, and you can find me there. I have a professional page there. And I also have a website, www.jenniferhuntmd.com. And then, of course, you can find me at the University of Arkansas for Medical Sciences, where I am a chair and actively involved in pathology world. So you can find me any of those places.
And that's all awesome. And I will put in a plug for your website. There is lots more information about what imposter syndrome is. And people can actually take this assessment and get an immediate grade and a percentage. And that's where they can also learn much more about your course, which Absolutely. I am hoping to take one of these days when I find the time. I also did find on your website, your podcast about time management. So that's also yes. on my list of things to do and listen to. But thank you so much for joining us today. I know lots of people have been listening and resonating and identifying. And of course, as we always say in medicine, the first thing is just making the diagnosis. So if somebody recognizes this in themselves, hopefully they can stop and do some of the tools and give themselves more positive, reaffirming messages or evidence to the contrary.
Well, thank you. This has been such a pleasure.
Thank you. Take care. And now you have a story about what your most interesting conversation was in the ladies' room.
That's right. Now we're here, except we're not really in the ladies' room. Yeah, this is a better ladies' room.
This is our ladies' room.
That's right.
Take care. Thanks again.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. And please join us next week for another episode of In the Ladies' Room with Dr. Donica. Real conversations with real women about really intimate topics.